Good morning, everyone. Today I'll be presenting my thesis topic titled Dengue Infection in Individuals with or without liver disease, Clinical and Virological Insights. Dengue, as we all know, is a rapidly emerging global health burden ranging from mild febrile illness to severe life-threatening disease. Hepatic involvement is a common and clinically significant manifestation of dengue infection. Transaminitis occurs in 65 to 97% of the patients, with AST typically elevated more than ALT, and liver injury in dengue ranges from mild enzyme elevation to acute liver failure. Recent meta-analysis data suggests that ALF occurs in approximately 2% of the dengue infection and is associated with high mortality of around 47%. This highlights the critical need to understand the liver involvement in dengue and its impact on clinical outcomes. So coming on to the pathogenesis of dengue infection, injury in dengue infection is multifactorial as it includes both viral and host immune factors, leading to release of various cytokines and chemokines, resulting in a cytokine storm. It includes direct cytopathic effects, immune-mediated injury, and drug-induced injury. Additionally, endothelial dysfunction and plasma leakage contribute to organ dysfunction. Now, dengue is classified into dengue fever with warning signs, and severe dengue according to the WHO 2009 classification. Liver involvement ranges from mild enzyme elevation to acute liver failure, which is associated with high mortality. So the lacuna in the literature is that only limited studies detailing about the clinical course and outcome of dengue infection in patients with liver disease are available in our country. Only case reports or case series highlighting dengue as a cause of ALF are available. So our primary objective was to study the clinical spectrum and outcomes of dengue infection among patients with and without liver disease. And secondary objective was to determine the occurrence of acute liver failure in dengue-infected patients. We also wanted to determine the seasonal trend in circulating serotype or genotype of dengue virus during the study period. So it was a prospective study on retrospectively collected specimens from 2021 to 2025. Clinically suspected cases of dengue infection in whom dengue test had been requested for 2021 to 2025 were considered in the study population. All consecutive patients of any age with serologically confirmed dengue infection during the study period were enrolled in the inclusion criteria. And further, these patients were categorized into liver disease patients and no liver disease patients. And serologically confirmed dengue infection patients were positive for dengue NS1 and or IgM antibody on tested specimen. So here we'll discuss the workflow of our study. We included all patients which are clinically suspected of dengue cases from 2021 to 2025. These were classified into serologically positive and negative cases. And for the confirmed cases, demographic and clinical details were retrieved from the HIS, and the patients were further categorized into liver disease and no liver disease groups. Archived NS1 positive samples were used for molecular analysis, and PCR was performed to determine viremia, followed by serotyping and genotyping in viremic cases. Finally, data was analyzed to compare the clinical outcomes. Now, coming on to the results. So, this slide shows the distribution of dengue infection in our study population. So, a total of 5,412 suspected patients were tested, out of which 357 patients, that is around 6.6% patients, were confirmed of dengue cases. Among these, 47.6% cases belong to the liver disease group, while 52.3% cases belong to the no liver disease group. In the liver disease group, dengue fever was the most common presentation, followed by severe dengue and dengue with warning signs. While on the other hand, in patients without liver disease groups, dengue fever remained most common, but dengue with warning signs was more frequent, and severe dengue was significantly lower. Now, coming to the baseline demographic and clinical details of the study population, patients with liver disease were older, more male predominant, and had higher severe dengue, longer hospital stay, and higher mortality as compared to patients with no liver disease. The baseline biochemical and hematological parameters of the study showed that patients with liver disease had significantly worse biochemical parameters in the form of higher INR, bilirubin, and transaminases. So, coming on to the etiology spectrum of liver disease cases, cases with, out of the 357 cases with liver disease were around 170, and the chronic liver disease formed the majority among liver disease cases, followed by the acute causes of liver disease, like acute viral hepatitis. Now we try to look upon the differences between the cirrhotics and the non-cirrhotic group. Our non-cirrhotic group included all the patients of acute viral and other causes of etiology. And on comparison, cirrhotics were older and predominantly male. Also, cirrhotics presented more with classical dengue fever, while severe dengue was higher in non-cirrhotic group. Uh, Now, on comparing the baseline biochemical and histological parameters of cirrhotics and non-cirrhotics, cirrhotics had significantly worse INR and bilirubin as compared to the non-cirrhotic group. Now, comparing the liver impairment in the study population, AST and or ALT was significantly higher in the dengue patients, and as the severity of the dengue infection increases, AST and ALT levels increase with AST more as compared to the ALT levels. This slide shows the stratification of liver impairment in dengue patients based on the AST and or ALT levels. Liver injury was classified based on the multiples of upper limit of normal, taken as 40 IU per L into normal, minor derangement, moderate derangement, and severe derangement. Normal derangement was defined less than 2 ULM. Minor derangement was defined as 2 to 4 ULM. Moderate was defined as more than 4 to 10, and severe derangement was defined as more than 10 ULM. And as we can see, severe derangement was more common in liver disease patients as compared to the no liver disease patients, with 38.8% patients here and 12.8% patients here. Now coming on to the clinical profile of patients with acute liver failure in our study, a total of 30 patients developed ALF, of which 60% were isolated dengue and 40% were due to other viral causes, that is hepatitis A infection. There were 11 patients, and hepatitis B virus infection, there was one patient. The mean age and sex distribution were comparable between the groups, and pediatric cases were relatively more common in the non-dengue viral ALF group, whereas the dengue-related ALF was predominantly seen in adults, although there's no much statistical difference. Overall, mortality was 33.3%, with high mortality observed in the dengue-related ALF, suggesting a more severe disease course. Now, this was a seasonal trend of dengue infection between 21 to 25, with peak post-monsoon months, with October showing the highest number of cases. Now, coming on to the molecular diversity of dengue virus, this slide highlights the molecular diversity as the dengue virus belongs to the Flaviviridae family, and this is single-stranded RNA virus with a length of 11 kilobase pairs. It is divided into structural protein named as capsid, pre-membrane protein, and envelope protein, and 7 non-structural proteins. And the genome, based on the difference in the E protein, virus is divided into 4 serotypes, that is dengue 1, 2, 3, and 4. And all the serotypes are further divided into genotypes based on the structural proteins. The red ones that I've highlighted here are the predominant genotypes of these serotypes in our country. On looking upon the molecular characterization of the virus in our study, we took out all the cases positive for NS1 antigen with a fever duration of less than 4 days. Among these, we took out 61 samples on which molecular characterization was done. Nucleic acid extraction was done using the manual extraction kit based on the spin column technique, and then targeting the E gene. We performed the real-time PCR to detect the viremia and serotypes. So all the samples with CT value less than 27 were subjected for genotype determination using in-house primers targeting the CPRM region for nested PCR, followed by Sanger sequencing in 36 samples. Now coming on to the distribution of dengue serotypes in our 56 samples, with the predominance of dengue 2 serotype followed by the dengue 3 and dengue 1. When we talk about the year-wise circulation of the dengue serotypes from year 2021 to 2025, from 2021 to 2023, dengue 2 was a predominant serotype in circulation, unlike in year 24 and 25, where few co-infected serotypes are also seen. Now coming on to the genotypes of dengue virus in our present studies. So a total of 36 samples were sequenced using Sanger sequencing, out of which majority of the genotypes are cosmopolitan, and only 2 samples belong to genotype 3 of the dengue 3 serotype. On looking upon the genetic diversity of the dengue 2 virus, we tried to construct a phylogenetic tree to understand its evolution, and all our isolates were clustered together, showing that they're genetically related with several isolates from other Southeast Asian countries, including Nepal, Singapore, Vietnam, Thailand, Indonesia. Now coming on to the discussion. So there are various serotypes circulating in Delhi since many years, and earlier data from our institute showed that a shift from dengue 3 to dengue 1 predominance, and subsequently during the 2015 outbreak, there was a shift from dengue 2. Later in 2017-18, circulation of dengue 3 genotype was documented. And in continuation of this, our study from 2021 to 2025 demonstrates predominance of dengue 2, specifically the cosmopolitan genotype. Now, this slide shows the pattern of hepatic injury in dengue infection. So, all the previous studies showed that AST levels were significantly higher than ALT. And in our study, we've also found the same, that AST predominance was seen more in as compared to ALT. And AST was seen in 75.5% of patients, which is consistent with the previous literature. And patients with liver disease showed significant higher AST levels than ALT, and higher levels of transaminases were mostly observed in severe dengue patients. Now we tried to compare the dengue infection in liver and no liver disease, and we found only one paper from ILBS by Dr. Kulkarni. And in their study, they divided the patients into three groups, that is Group A with no underlying disease, Group B with chronic liver disease, and Group C with CLD plus cirrhosis. And they found that dengue fever was seen in 89 patients, while severe dengue or dengue hemorrhagic fever was seen in just 2 patients. And the Group C had less evidence of hemoconcentration, prolonged INR, and thrombocytopenia, and prolonged hospital stay. Paradoxically, low AST ALT was seen in cirrhotics, and length of hospital stay and mortality were more in liver disease as compared to no liver disease. And in our study, we found that liver disease patients were less as compared to non-liver disease patients, and AST predominance was observed more in liver disease group, and length of hospital stay and mortality was more, which is comparable to the previous studies. And severe dengue, liver disease group had 18.8%, and no liver disease group had 5.3%, and dengue 2 serotype was dominant with cosmopolitan genotype. And coming on to the acute liver failure in dengue, so the previous study, this is a meta-analysis study which came out in 2024, which showed that pooled ALF incidence in general dengue was around 2%, and ALF incidence was higher in children, that is 5%, as compared to adults. And in severe dengue, ALF incidence rises to 17.3%. And dengue-associated ALF carries higher mortality. In our study, we found that ALF was seen in 30 patients, which made out 8.4%, and ALF incidence was seen higher in adults as compared to children. Isolated dengue ALF was seen in 60%, and co-infected cases were seen in 40%. And the overall ALF mortality was seen in 33.3%, and which was more in isolated dengue cases as compared to ALF with other viral pathologies. So now coming on to the limitations of our study, it was a retrospective single center study, and the primary versus secondary dengue infection could not be determined, and all biochemical and hematological parameters were recorded at a single point at the time of hospital admission or OPD visit. Consequently, temporal changes and trends in these parameters could not be ascertained. Now to conclude, dengue infection was identified in 357, that is 6.6% patients from 2021 to 2025. Liver involvement was observed in significant proportion of dengue patients with AST predominance, and patients with liver disease had a significantly higher proportion of severe dengue compared to those without liver disease. Poor outcomes in terms of mortality and length of hospital stay in liver disease patients as compared to no liver disease patients. And ALF occurred in 30 patients with 60% due to dengue-related ALF, and higher mortality in dengue ALF, that is 44.4%, and it was predominantly seen in adults with associated poor outcomes. Dengue 2 cosmopolitan genotype was the predominant strain throughout the study period.
From the guide.
So this is, we try to look upon the dengue infection, especially in the liver disease. And when we search the literature, there is a lack of literature, and dengue-related ALF, when we try to find out, there was just in a form of case reports or case series. So with this mind, we thought, like being a liver-centric hospital, to study the dengue infection in this group of the population, and we found significant results that cases with the liver disease has poor mortality, poor outcomes in the terms of longer hospital stay, as well And the isolated dengue-related ALF, we found in 60% of the cases where dengue was the only cause, underlying cause which we could identify patients landing in ALF, with mortality reported in approximately 44%.
I do agree it's an interesting area, but I think there's a lot of literature available in dengue liver failure. I've seen reports as big as 257 cases, so I don't recollect it. Did you correlate with the viral load of dengue? Did you correlate with severity?
No, sir, we have not.
And also the dynamic profile or trend of the viral clearance or persistence. Like in hepatitis A, it has now come to be known that people who have HIV and ALF, they don't clear. The virus persists for long. So dengue ALF versus others, that could be one area. How many had liver biopsies post-mortem? Was the virus checked up into the liver tissue? Mm. And also, one of your secondary objectives was to see the incidence of liver failure in dengue. We are liver centric, so all liver patients will come here. So we may have a bias. This can't be seen as an incidence, it is the profile of so good work, but much more should be done in this. Any other comments? Yeah,
So it was an excellent,
please,
it's an
Rakesh.
excellent presentation. Thank you. And I would just like to know, when you say this mortality is 44% in liver disease, so this is not with respect to the liver disease in the background. Is it just ALF or what? So, ma'am, our liver disease patients were the ones who had pre-existing liver disease. And when we tried to, like we included all the patients, ma'am, of chronic liver disease, it means we cannot club acute liver failure. I'm just trying to tell you, because that is a very different presentation with respect to the underlying chronicity, and the spectrum also changes. So my suggestion to you is, from this study, you can take forward and take out all the ALFs, because we've seen secondary HLH in all these patients, and based on the organ involvement, because that will be another very interesting series, just looking at the acute liver failure.
Can I add, Raki, to your comment? Yes, this was what we discussed earlier. That should we take pre-existing chronic liver disease and like the native liver or diseased liver? So I think the ALF cases that she's showing were all in the that data also you have, where the liver was absolutely normal and then that led to dengue. So the isolated dengue infection was more associated with ALF, where there was no other pre-existing liver disease. That means a native liver just acquiring this thing, and more seen in adults. So interesting data which we got was that a recent good meta-analysis came from AIIMS New Delhi, where they have shown that pediatric dengue infection leads to ALF in the primary dengue. From our center, as rightly said, yes, we can work more on this. We found that, or maybe it is that the adult patients are more predominant. We found that severity of dengue infection and ALF in adult liver disease patient is also very common. So we can work more on it. Unfortunately, as you said, sir, the viral load correlation with severe dengue and ALF could not be done because I think we did not find any viremia. So most of the liver injury and damage occurs as a post-immune response. And since dengue virus is not hepatotropic, even in the liver biopsy will not be able to get. And the viremia is usually, as the severe dengue sets in, the virus PCR becomes negative. And it is the IgM and the other factors which leads to
We haven't studied. In fact, this is simply a characterization of patients that over many years.
Yes.
But in the research question, the research question is to be not the prevalence or the incidence. What is the research question in the whole thesis? What is the research question in the thesis?
So we could determine serotype and genotype.
Question. What is the research question?
Actually, to look
I
at
think-
the
I think she was trying to do the genotype. That was the main message
circulating
from
and,
these collected samples.
and what is the incidence actually, sir, of dengue?
Not the incidence. Incidence is you have no, but I not student is not at fault or the faculty. But I think the research boards when they clear these protocols, they must be very clear. And there has to be a good research question. It's not a characterization. Okay, Arjun, thank you.
Morning, everyone. I'll be presenting my thesis titled Efficacy and Outcome of Balloon Occluded Transarterial Chemoembolization for Treatment of Hypovascular HCC. HCC remains one of the leading causes of cancer-related mortality worldwide. Liver-directed therapies, particularly TACE, have emerged as an important treatment modality for patients, while conventional TACE and drug-eluting bead TACE, that is DEB TACE, they remain the standard of care for intermediate stage HCC. Its efficacy is often limited in hypovascular tumors due to insufficient drug delivery and embolization. On the other hand, balloon occluded TACE, that is BTACE, which is a relatively newer technique, it utilizes temporary occlusion of the feeding artery with a microballoon catheter to alter the local hemodynamics, reduce the antigrade washout, and thereby enhance the drug accumulation within the tumor and enhance the therapeutic outcomes. So in this, we can see that in balloon TACE, we insert a microballoon catheter and then we can inflate it. And after inflation, we inject the drug. So because of this, there is a less amount of reflux also, and we are able to deposit a higher amount of drug within the tumor as compared to conventional TACE, where there is no such balloon. So what are the lacunae in literature? There are no studies evaluating the efficacy of balloon TACE in hypovascular HCC, with more studies on VTACE being on hypervascular HCC. And there are very limited studies which evaluate the efficacy of conventional TACE and DEB TACE in hypovascular HCC. Coming to the aims and objectives of the study, the primary objective was to evaluate the treatment response of balloon TACE in hypovascular HCC. And the secondary objectives were to evaluate the survival, the complications associated with BTACE in hypovascular HCC, to compare the efficacy, outcome, and complications in hypovascular HCC of balloon TACE versus CTACE and DEB TACE, and to also see how many additional sessions of TACE or ablation were required for complete coverage of the target lesion. The materials and methods, patients who have undergone TACE, which on the pre-procedural multiphasic imaging, which can be CT, MR, or PET CT, it is hypovascular, and they have complete workup for evaluation. The study was a single center observational study with retrospective data collection. So the definition of hypovascular HCC was defined as a lesion which on multiphasic contrast enhanced imaging, CT, MR, or PET CT, it demonstrated absent or minimal enhancement on the early or the late arterial phase, with washout on the portal venous or delayed phase, without an enhancing capsule that could be threshold growth, and other ancillary imaging features which could suggest HCC. The various ancillary features suggestive of HCC included non-enhancing capsule, nodule and nodule appearance, mosaic architecture, blood products in the liver lesion, fat in the lesion, which was more than the adjoining liver. Coming on to the inclusion and exclusion criteria. Inclusion criteria were patients with a radiological diagnosis of hypovascular HCC who underwent TACE, and there should have been at least one treatment imaging for assessment of the treatment response. And exclusion criteria for patients who had hypervascular HCC on the pre-procedural imaging and patients who had undergone any prior locoregional or systemic therapy for the target lesion prior to this, and patients who had incomplete imaging or follow-up. Data collection, pre-procedure records in the form of demographic profile, baseline liver function tests, etiology, performance status, and tumor markers were recorded. Then the imaging was the pre-procedure contrast enhanced multiphasic imaging. The patient's procedure underwent, it was TACE, it could have been VTACE, conventional TACE, or DEP TACE for hypovascular HCC. And the first imaging follow-up was done at 4 to 6 weeks, and the subsequent imaging follow-up was done every 3 months. And the post-procedure LFT and tumor markers were recorded. Coming on to the study flowchart, a retrospective review of the pre-procedural imaging was done for all patients who underwent TACE. The multiphasic contrast enhanced CT, MR, and PET CT were reviewed. Hypovascular HCC lesions treated by TACE were included in the study, which included 36 for BTACE, CTACE was 35, and drug-eluting BTACE was 9. The baseline parameters were evaluated, including demographics, the LFT, tumor markers, etiology, performance status, size, and the location of the tumor. And the post-procedure parameters included the LFTs, tumor markers, and any complications. Imaging was done. The first imaging was done at 4 to 6 weeks, and then subsequently 3 months. And also the number of additional sessions of TACE or ablation, which were required for the complete coverage of the target lesions, were also important. So total 90 patients were identified who had hypovascular HCC who had undergone TACE. 10 were excluded due to incomplete records or lost to follow-up. So after that 80 patients were left, and among these 36 underwent balloon TACE, 35 had undergone conventional TACE, and 9 had undergone DEP TACE. So total patients for evaluation were 80 of hypovascular HCC. So the definitions, the treatment response, it was based on the modified RECIST criteria, and it was categorized into complete response, partial response, stable disease, progressive disease. However, additional features were also kept as there was hypo enhancement. So additional features of response which had to be considered was if there was internal necrosis, intralesional lipidol deposition, any shrinkage in size of the lesion, absence of delayed washout, and reduction of tumor markers. Coming on to the results, the baseline characteristics, 86% patients were male from the balloon TACE group, while 84% were male in the other TACE, the CTACE and DEP TACE group, while females were 13.9% in the balloon TACE group and 15.9% in the CTACE DEP TACE group. And the age, the mean age in the balloon TACE group was 61, while in the conventional TACE DEP TACE it was 63. The etiology, the most common etiology in both the groups, it was NASH, followed by hepatitis B and hepatitis C. Childhood status A was most common. In the balloon TACE, it was 66%, while in the conventional TACE DEP TACE, it was 50%. Performance status 0, it was in the balloon TACE was 72%, while in the CTACE DEP TACE was 60%. And the BCLC stage B, it was 39% in the balloon TACE, while it was 56% in the CTACE DEP TACE group. The baseline lab parameters, the AFP in the BTACE was around 590, while in the CTACE DEP TACE was 1044. The PIVCA, mean PIVCA was 1117, and the balloon TACE when it was 2783 in the CTACE DEP TACE group. The mean size of the treated lesion, it was 40 mm in the balloon TACE, when it was 40.1 in the CTACE. But there was a higher variation in the tumor size in the CTACE DEP TACE group. Coming on to treatment response, complete response was seen in around 61% of patients in the balloon TACE, while in the CTACE DEP TACE group it was seen in 31.8% patients. The objective response in the balloon TACE was 94%, while in the CTACE DEP TACE was 79.5%. Comparing the liver function parameters between these two groups, the AFP was the balloon TACE was 586 pre-procedure, and at 1 month follow-up was 238, while in the CTS depth group was 1044, the baseline, and 950, the post-procedure 1 month follow-up. While the PIVCA, the baseline in balloon days was 1117 and post-procedure was 236. While in the CTS depth days, it was 2783 and the 1 month follow-up was 1783. Complications in the balloon test, it was seen in 36% patients, while it was seen in the other was 56%. The p-value it was 0.06. The most common complication was transaminitis. Other complications seen were post-embolization syndrome and abscess formation was seen in one patient in the CTS depth test. Requirement of reintervention in the form of TACE or ablation for the target lesion. It was required in 13.9 patients, 13.9% patients of the BTS group, while in the CTS depth test, it was seen required in 43% of patients, which was statistically significant. Coming on to survival outcomes. Progression-free survival, the mean PFS in the balloon test was 15.6 months, while in the CTS depth test was 9.3 months. And this is the Kaplan-Meier curve. In the blue, we can see this is the balloon test, and the dotted red line is the CTS and depth test. And this was statistically significant. The overall survival in balloon test was 23 months, while in the conventional depth test group, it was 25 months. But it was the p-value was not statistically significant. It was 0.56. And here in the blue, this is the balloon test, while in the red is the conventional test and depth test. Just a few examples showing the cases. This is a multiphasic imaging. We can see this is the arterial, portal venous, and delayed phase. In the arterial phase, there is no significant enhancement within the lesion. And on the delayed, there is washout with capsule formation, which was suggestive of hypovascular HCC. So balloon test was done for this patient. This is the inflated balloon, and this is the deposition of lipidol within the tumor. And this is the intra-procedure cone beam CT. We can see that there's deposition within the lesion and a little on the surrounding liver. And this is the follow-up imaging after 1 month, where there is dense lipidol deposition within the tumor. Another example, this is the MRI. Again, in arterial, portal venous, and delayed images, we can see that there is no significant arterial enhancement. However, there is washout and a capsule formation consistent with hypovascular HCC. So, test was done for this patient. This is the intra-procedure cone beam CT with lipidol deposition within the lesion. And this is the follow-up imaging. This is at 1 month, and there is dense deposition of lipidol within the lesion. And again, this is the follow-up at 6 months. There is a reduction in size of the lesion. And another example demonstrating hypovascular HCC, no significant enhancement with washout and capsule formation. And this is the intra-procedural cone beam CT with deposition of the drug. And this is the follow-up imaging at 1 month with type 1 lipidol deposition within the lesion and complete response. Coming on to discussion, there were very limited studies regarding hypovascular HCC. The study by Shi et al. It compared depth TACE with conventional TACE for hypovascular HCC. It was a single center retrospective study. It had 98 patients with hypovascular HCC. 46 had undergone depth TACE and 52 had undergone CTACE. And the study demonstrated that depth TACE, it had significantly better tumor response, longer progression-free survival, overall survival, with a similar safety profile as compared to conventional TACE in patients with hypovascular HCC. There were no studies of hypovascular HCC on VTACE. And this study, which is a meta-analysis by Liu et al., it compared VTACE versus conventional TACE for HCC. And this study, it showed that balloon TACE, it achieved significantly higher tumor response than conventional TACE while maintaining a similar safety profile, while further prospective study long-term survival benefits. So coming on to the limitations of our study, it was a single center retrospective observation study, which makes it dependent on medical record documentation susceptible to selection bias. The sample size was relatively small, of 80 patients, while for balloon TACE, there were only 36 patients, which limits the statistical power of the study, there was variability in follow-up duration among the patients. The follow-up period was short, especially for PTs, as it was a relatively newer technique. So to conclude, balloon TACE demonstrated superior therapeutic efficacy as compared to CTACE and DEPTACE in patients with hypovascular HCC. It had higher complete and objective response rate, resulting in improved local tumor control. Patients who had undergone PTACE, they had a longer progression-free survival and required fewer repeat TACE and ablation sessions for the target region. Although overall survival was not significantly different, the improved radiological outcome and lower progression rates favor BTS as a more effective low-poison therapy. The complications were comparable to the conventional and death-based group. The enhanced efficacy of balloon TACE, it is likely due to the temporary balloon occlusion, which improves the intratumoral deposition of lipidol and the chemotherapeutic drug within the target region. Thereby, it can overcome the poor arterial hypervascularity nature of the hypervascular HCC, while at the same time, it reduces the reflux and non-target embolization. It can be considered a preferred treatment option for hypervascular HCC, particularly in patients who are suitable for embolization. And further prospective multicenter studies with larger cohorts and longer follow-up is required to validate these findings.
Comments, very good. Comments from Lakshmi?
Sir, our aim of this new technique is to increase drug deposition in the tumor.
We go to primary objective while he's commenting. Go to primary objective.
Treatment response of balloon.
This is not a comparative. The primary objective was to see the treatment response of BTS.
If more drug is deposited in tumor, then progression-free survival.
Any other comment? Because when I read the primary objective, it was only for BTS. Comparison was not the primary objective. The whole presentation is on what is the response rate of BTS, and normally I thought you do not take hypovascular agents. You say it's not good for taste. How many were excluded? Were you taken in as out of how many you excluded to get
90
this?
patients were there who were hypovascular. Out of that, 10 we had excluded because they had incomplete data or follow-up. So total 80 patients could find what hypovascular HCC.
Based on imaging, exclusion is relatively biased because mostly lesions are which have capsule are included in BTS. If hypovascular and ill-defined lesion, then we usually exclude treatment.
Did you achieve higher dose? You say your higher dose can be. So what dose could be achieved?
Density of lipid drug injected in each case is relatively same, 15 milligrams.
The dose is same, and the side effects less. The adverse events, liver failure, or post-stage liver failure. It shows the stats of the complication being less.
But not statistically.
No, इसीलिए तो मैं पूछ रहा हूँ. Where are the lower complication rates? So how do you say your BTS balloon test is superior?
Can I also forward the comments from you? So the thing is, what is your protocol? And if this is a retrospective study for hypovascular lesion, how did you decide which patient to be considered for which therapy? First is this question. And if it is like you have changed over the period of time, that did not come out from this data, that this was the historic cohort. So if they have been randomly assigned to one of the other means based on whatever judgment you made, that did not come out. In a retrospective, then you should do a propensity risk score matching. And supposing it was a historical or something, then you should have shown the characteristics of the patients, that it was similar. And then you should have done a multivariable analysis to show that this intervention has improved outcomes with respect to adverse events, adjusting for all the other factors which are there, which make a difference in the treatment response. So that is what I would suggest for this data.
It's an important data, but it needs to be reanalyzed because I do not find any superiority being to the details. Any other comments?
Responsibility is survival or something else? What is the definition of response?
The first is,
Same 23 months or so.
yes, a thesis for increase relatively more started in 2023. Yes.
Don't feel disheartened. It's not that you have done a wrong work. As a student, the idea is for discussion is to see how you can take it forward. It's an important data, but I'm not sure the data is analyzed. It's not one can look into again. um, What are the variables which determine, as Rakesh says, propensity matched? Any other comments? Yeah, Dr. Manoj.
We don't have p values for post embolization syndrome. 25% versus almost 50.
Yeah, that could be post-embolization syndrome.
That
Could
is
be significant. You are right, Manu. Was it significant?
Yes, that lead to appendices for people when large size lesion are included in conventional things and relatively small lesion in conventional. So we apply appendices for then we find. Okay.
Location of the case, did it make any difference? Site of lesion?
Site
No. No more comments. So thank you, both the presenters. Okay.